This program is brought to you by Stanford University. Please visit us at stanford.edu.
Well, thank you very much for the invitation. I would like to thank Dr. Fernando Mendoza and Dr. Gabriel Garcia for the invitation and wonderful day schedule that I have been doing this day, that I met a lot of interest people and discussed our program. And I'm very glad being here, and I hope you can get to know a little bit more about the Mexican healthcare system, the Migrant Health program, and some of the health problems that we are facing and the challenges we are facing nowadays in Mexico. So I'm going to talk about the Mexican Migrant Health program, which is a recent program that it started in, I guess, around 2003, as I was telling you before. So it's a very recently installed program, but so I'm going to be addressing that. And in doing that, I will talk first a little bit about the health situation in Mexico, briefly or more or less, so you can see that in what parts we are having the common problems like in the United States, and what the challenges that we are facing. Then how we are organized in the Mexican healthcare system, so you can notice the difference between the migrant workers here, what they are expecting in terms of health in the United States, and because we have very different systems between Mexico and the United States and different approaches to the same to the problems. And then I will be talking exactly, specifically about what we are trying to do and we are doing in the Migrant Health program. So about the health situation in Mexico, we are going through two transitions. First, the demographic transition, and then the epidemiological transition. This demographic transition is that, look at this pyramid, population pyramid. In 1975, it was a very wide-based pyramid in which we have most of our population was under 10 years old, and being the more of the population was less than 5 years old. And nowadays in 2000, now is shortened this population less than 5 years old, and we have more young people, no? From 15 to 35 is the bulk of the population, actually starting from 10 to 15 years. So now we are having a shrinking population of 5 years old, minus 1.3, and older population going 3.8% on population over 65 years old. So we are projecting that in 2025 we are going to have a lot of population in the older stages and all the consequences that it imply on chronic diseases, etc. And we are also going through an epidemiological transition in which you can see since 1950 to 2000, in which how it has shifted from communicable diseases, which were the most part in these years, and now more and more we have non-communicable diseases in the mortality distribution and injuries. So now, and we've projected that in 2010 and 2025, we're still having much more burden of disease of non-communicable diseases and less communicable diseases. This is another slide that shows you the shift on diseases that we had through the years is shrinking the communicable diseases and going up the non-communicable diseases, although we still have to contend with communicable diseases. Now this other one is just to show you the great inequalities in health we have. This, I'm talking about mortality for children under 5 years old by infectious diseases by state in Mexico. So these states are the poorest with Chiapas, the state of Mexico, Oaxaca, Puebla, Tlaxcala, and Guerrero, which are in the south part of Mexico, and look at the big difference from the more affluent type of states in the northern part of Mexico. So we still have to deal with a lot of inequalities in Mexico. Here, by the way, these states are the ones who have the most density of indigenous populations in Mexico. We have around 10 million, 10% of the population is indigenous population. They live in rural areas and scatter around the mountains with difficult access to healthcare, and this is translated and reflected in the high mortality rates that this population have. For example, in the general mortality for the whole population in Mexico, on the 5 major killers are non-communicable diseases or chronic diseases like diabetes, cancer, etc. Whereas in the indigenous population, we still have diarrheas and upper respiratory tract infections as the major causes of disease. So that also places some important problems because we have to deal with infections and more with chronic diseases. Now in this graph, I just wanted to show you the main determinants of major killer disease in Mexico as measured and DALYs. So overweight and obesity is one of the major contributors to almost 20%, let's say, for 1 year of DALY. And then also we have hyperglycemia, which is diabetes, alcohol consumption, high blood pressure, unsafe sex. So lots of things that can be modified through lifestyle changes, no? That we can have a lot of actions into those that are the major problems that we are facing nowadays in Mexico. To put you an example, for example, of this is like the overweight and obesity prevalence and the changes we have had. We made 2 major surveys in Mexico, one in 1999 and the other one in 2006. And here you are seeing overweight and obesity in women. So in girls, you see the shift from 20.2 that we had, and now we have 26.8, meaning a 33% increase in this age, in this stage, in these ages on girls. And then teenage females is 14% increase, and women 40% increase. So even though in terms of prevalence of overweight and obesity in women, you have more in the United States as a whole, the increase is being much higher in Mexico, the change in few years. So we are talking about that we have an epidemic proportions of overweight and obesity. Now the other, one of the strategies to deal with this problem is through, we are saying to the whole society as a whole, promoting physical activity and nutrition education. And once we have focalized and selected the problem, then we go into weight reduction and control programs and nutrition education programs also that we are implementing now. And we are doing this through all the agencies in Mexico. Here we're saying the Ministry of Health, Education, Development, Congress, etc., to have more food labeling and regulatory encouraging practices in order to address the society as a whole. And in a specific, once you have the problem, then we go to the academic societies and to the health sector to contend with overweight and obesity. Okay? So this is the new strategy. That's what I wanted to put it you here, because in Mexico, every 6 years, with a change of administration, we come up with a national health program. I'm going to talk about it a little bit more about it, because we have the notion that we have to set a policy and a program to address these problems as a whole. Then the other problem we have is diabetes. This is another example that I wanted to put you, that in the last survey, we detected that we have 4.2 million people with diabetes. There are much more because these are the ones who know that they have diabetes. But there are many more that don't know that they have diabetes. But let's say that of these 4.2 million people that have diabetes, 3.2 reported that they are taking a treatment, mainly by oral hypoglycemics. And then, but diet, you can see here, of these, only 20% are following a diet according for the diabetes. And only 4% of it, or around 10% of them, are doing exercise. So we still have a lot to work as in a public health interventions to increase the diet thing, that they follow diet and that they increase exercise. So it's very few persons are following these other complementary treatments. And again, for diabetes, we're having a strategy to contend with the whole population as a whole, promoting physical activity. And then once they have, or they are risk factors for the persons that have, that are likely to have diabetes, we have weight control and reduction programs, and then we do interventions to have adequate levels of glycemia. And again, we have a regulatory thing like nutrition orientation. We set up a norm regulatory thing in order to homogenize all the different messages that are given to the population in terms of nutrition education. So you see, I mean, many companies copy the pyramid, the food pyramid that you have in the United States. In Mexico, we have a circle, and now we made it mandatory to everybody to follow one of those schemes, and the one that won was the circle, the Mexican one. So, so this just to unify the concepts and don't confuse the population with what are the recommendations for health education. Okay, and these are all the other partners that we are having in order to target this population. So, well, as you can see, the challenges of the health system are, first of all, the increasing cost to treat the demand of chronic disease and longer treatments due to the shift of the aging of the population, and that they are living more, and we have to deal with that. And we also need to continue to deal with infectious diseases and with the emerging health problems that we're having right now: obesity, depression, smoking. We have a lot to do in this area of smoking, because Mexico is in the rise, and women are the ones that are smoking more, and we don't have these policies, restriction policies for smoking in closed environments. In restaurants, you could go and smoke everywhere. So we have a lot to do on the regulation of smoking, and also we have to cope with other emerging diseases like tuberculosis, SARS, pandemic influenza, or HIV. Now, how is the organization of the Mexican health system? As I was telling you earlier in lunch to some of you that were there, Mexico has the philosophy that, or the aim that, or the thought that all Mexicans have the right to health. So ever since it was developing since the 30s, that this was a right of the population. So we have now in the Constitution, in our fourth article of our Constitution, the express that it's a right of all Mexicans to have health, access to health. Of course, we still haven't reached that goal, but it's just to think that if we think that it's a right, the whole health system is going to go to reach that objective. And also, even though we have different health organizations that deliver health, that I'm going to tell you just in a minute, I mean, we have a national health system. And that's why we come up every 6 years with a national health program in which all agencies, health agencies, either public health or hospitals and clinics, are under the same guidance of this national health program. So basically, our health system is organized in these three big blocks. No? First, governmental organizations. They provide services for the uninsured population, and mainly that's the Ministry of Health. And I'm quoting this other program, IMSS Oportunidades, because this program covers like around 10 million Mexicans, and the rest, the Ministry of Health. And these are uninsured population, meaning people that are not in the formal sector. They are not workers in the formal sector. They are people that are poor, they are farmers in rural areas, and self-employed population. Then the other one is the Social Security. And Social Security covers workers in the formal private sector of the economy, and also state and federal workers, the armed forces, and the oil company that is very strong. And thirdly, we have the private sector, which is made up of lots of healthcare providers, and they give hospitals and clinics for a profit basis. But they cover around 5% of the population. So this is, in general terms, what it is. So in Mexico, what is known as Social Security system is these health services provided to the formal sector, to the workers in the formal sector, and they give not only health care coverage, but they include medicines, they give unemployment insurance, they give disability insurance, life insurance, and retirement benefits. And I do this because in the United States you have this Social Security, and usually they get confused when we are saying Social Security, and it's very different than from your Social Security. This is only the coverage they do to the workers in the formal economy. So roughly we have 50 million that are covered through the Social Security, and 50 million that are not covered by Social Security. And in theory, again, 50 million people are covered through the Ministry of Health. Of course, we don't have enough clinics and infrastructure to deal with these other 50 million. But now there was a big health financial reform in Mexico last administration, and we did what we called the popular insurance. And in this popular insurance, the idea is to provide with health care to these 50 million that don't have Social Security. So in this graph, even though it's a little complicated, the idea is to tell you we have first Social Security, and it's financed through the federal government, through the employer, and through the employee. And each of them pays 30%. So 30 is a 30%, 30%, and 30%, and they provide to these 50 million people. They have their own hospitals and their own clinics. And they provide services to the formal sector workers, to the families, and the retirees, no? And they give all these other health, disability insurance, pensions, etc. But the idea is that it's very inequitable because they have their own hospitals and they have their own physicians. They pay for their own physicians, their own nurses, etc. And in the other side, we have the Ministry of Health, who is through the federal government, and we also have our own hospitals, our own clinics, our own doctors. And then the private sector, who is paid by employers and individuals. They are pretty much like HMOs, and they are aimed at middle and upper classes. And this is only 5% of the population. These other ones are the other 45%, and this is 50% of the population. And there's a lot of overlap among them. So this is not a perfect scheme, because still the people that have Social Security also can go to the Ministry of Health, hospitals and clinics. And so it's very segmented. So depending on if you have a formal job, is that you're going to have access to these hospitals, and if you don't have a job, then you go into these hospitals and clinics. So the main problems we have is the fragmentation and lack of coordination among these three systems, then the inequity in access to care, and the dissatisfaction with services provider, and imbalances in resources, being the Social Security the one who has the more money, because they are being financed by the taxes, by the employers, and by the employees. But well, nevertheless, that's the aim, to cover the whole population, even though we have these problems of imbalances and all that. No? Now, our model of delivery healthcare is, we go, well, as everywhere, I don't know if here you have the same, is primary health care, then secondary level of care, and then tertiary care. No? Pretty much that's the way we work. Primary health care, we have through health promoters in rural areas. They go into, we have around 150,000 health promoters, and they are usually people from their own communities, and they provide health, or pretty much health promotion to the community. And then they go to the clinics, who are primary health care. Then if they are problems that can be solved at that primary health care clinic, then they go to the hospitals, which pretty much are the secondary care, and then they go to the tertiary healthcare providers, which are the national institutes that we have along in Mexico, or to specialized clinics. No? Okay, well, now talking about this is like the background, and so you can understand how the migrants that come here are expecting to go into any clinic and receive services. And as you know here, well, it's quite different than in Mexico. No? So there are estimates that there are 28 million Mexican Americans or from Mexican descent in the United States. From these, 17.1 are Mexican American, and I will just want to stress the Mexican-born population that are around 11 million people. From these 11 million Mexican-born living in the United States, around 6 million are without medical insurance, and also around 60% of them have irregular migratory condition. So we are estimating that around 10 million persons of Mexican origins are in need of access to medical insurance. You yourselves have a problem, even with not Mexican American, but in American population, there are a big proportion of them that don't have health insurance or health coverage. So this applies the same to the Mexican-born population living in the United States. And what are the main causes of the Mexican migration to the United States? Well, mainly is because of the geographical proximity. We have been migrating to the United States for centuries, all the time. Also because of the increasing regional integration, and also because of the demand of Mexican workers in the United States labor market. But the main thing is the economic asymmetries between the two countries. So we have different wage differentials, very high in the United States. I mean, as I was telling you earlier, what you pay here for a Mexican or for whatever worker for per 1 hour, that's what they earn for the whole day in Mexico. No? So it's very attractive to Mexicans to come here because they are going to get paid much more, and they are going to work the same, pretty much. And also, of course, the inability of the Mexican economy to fully absorb a constantly growing labor supply. As you could see, that's going to keep on going for the next several years. For the next 10 years, we're going to have many people going into the labor force, and we can't cope with all those. And that's also for us a way to cope with our problem is that they come up here to work. No? And well, These 10 million or 11 million Mexicans living in the United States, around 30% of them are women. You have much more beforehand. Several years ago, there were mainly men who came to work in the United States, and now more and more women are entering into this migrant workforce. 77% of the agricultural workers are Mexican immigrants, as you can see, almost 80% of them. So pretty much the agricultural sector in the United States is performed through Mexicans, immigrants. And of those, 55% lack any type of medical coverage. And they tend to have a relatively low level of education in terms of your standards of education, but for the Mexican standards, they are considered like medium level education. So the people that are coming here to work are not the poorest of the poor in Mexico. Really, the poorest of the poor are there stuck in Mexico. They can't leave. So they are a little bit better off, and they come to the United States. And also they have a history of migration. Usually in different states of Mexico, there's generations coming and going. Usually it was a circular type of migration. They came for a certain amount of period of time, and they went back to Mexico. Nowadays, with this more enforcement of the border, now they tend to stay longer, or not going down anymore, but staying here. And then when they stay here, what they do is they bring their families up here. No? And we did a study recently, and that shows that people that have much more tradition of migration to the United States and have a lot of networks and support for living in the United States, they cross the border without much problems, even though the tightening of the security. Whereas the people that are dying on the border crossing and all that in the desert and having all these problems is people that don't have these networks, and they don't know people, and they are just wanting to come and risk their lives in the crossing, which there are a lot of people who are doing that. Now in California, we're saying of all California residents, 1 in 4 are of Mexican origin, so 8.5 million, and almost 1 in 9 are Mexican born. And you can see here where they concentrate the highest density of population of Mexican Americans, no? Or Mexicans here in the border region and in the central valleys of California. Well, so just to summarize then, I will say that the migration process per se has several risk factors for the migrants. A lot of them die in the process. 55% of them lack any type of health coverage, and also poor access to preventive and curative health services, and the changed lifestyle and occupational profile of migrants directly impact their health. And so that we need to, in order to take into account these situations, in order to design a migrant health program that I'm conducting in Mexico. So in September of 2000, how it came to be this migrant health program. In December 2000, there was a joint statement for migrant health signed by the head of HRSA, or we were discussing who was it, but it's HHS, the Health and Human Services Administration, no? And the Ministry of Health signed this joint statement that had 2 main objectives. First, to develop activities to meet the health needs of the Mexican migrants, and to strengthen binational collaboration on migrant health issues. And that's why, at that time, the Ministry of Health came up with this program. Actually, it wasn't right immediately. It was more in 2001 or 2002 when it started to take shape, this program. And well, the objective is this one, and we are emphasizing on I would like to emphasize on the binational collaboration on health promotion and healthcare delivery, and also services that are culturally appropriate. So that's the main objective of the program we're doing in Mexico. So it has to be binational and culturally appropriate, the interventions that we design in health promotion. So we have 4 strategies dealing first with collaborative institutional collaboration of the migrant health. There are lots of institutions in Mexico that somehow they have something to do with migrant health. So what I want is that in Mexico, any institution that has to do with health that come through us, no, to canalize and focalize our efforts in one program. The other strategy is to promote binational public awareness of the migrant health issues. In Mexico, as well as in here, people are not that aware of the problems that migrants have and the huge amounts of population that are leaving our country. 10 million Mexican born are leaving the country. I guess their going rate like around 600,000 per year coming to the United States, legally or illegally. And now people are aware of this because of the amount of money that is sent to Mexico from these migrant workers. For one, they don't leave their homes and come here and forget about their families. They call, like 80% of them call every week to Mexico. So they are very, very much in communication with their families in Mexico. And they send money, we calculate around $20 billion a year. And that is making an impact in the Mexican economy, a very important impact. So they are developing programs in which migrants or organization of migrants put some monies, then the Mexican government gives the same amount of money to develop their communities of origin. And that's a very successful programs that are done in the development ministry. We have a ministry of social development, and they are financing that type of programs. So migrant workers are organizing here to send money there to develop their own communities. So that's the second strategy. And the third strategy is to provide support services to the migrant population and their families. I will go more in detail into this strategy. And finally, to foster binational research on migrant health, because one of the problems also is that we don't know exactly what health problems they have. And pretty much because they are a moving population, no? Also because of the not having papers, or they are undocumented, well, they don't want to be telling what they have. Of course, we are doing some research and we are getting to know what health problems they are facing. So for example, some of the activities we do in each of these strategies, as you can see, we have a workshop for health professionals. Here we do it with this institution, which is the Institute of Mexicans Abroad. And they organize an Institute of Mexicans Abroad, that they are volunteers all around the United States. Mainly are professional people that are living here for several years. And what they want is also to address the needs of the migrants. And what they do, if they work in clinics and in hospitals that are delivering service to migrants, then we do these exchange programs that they go visit Mexico, and they give several lectures in order to know more about the healthcare system and also about the educational system that we give in Mexico. We advise the Mexican Congress on migrant health issues. Whenever they want to do a resolution or they want more information, we provide with them. We collaborate with this is the new Commission for the Development of the Indigenous Population. You know, more and more there are more indigenous population coming to the United States as migrants, and they don't even speak Spanish, so they don't speak very well Spanish. They speak their own language, and they don't speak English. So there's really a language barrier for these people. We collaborate also with the Border Health Association. This is the U.S.-Mexico Border Health Association is one that works in the border. It has been there for 70 years now, so we also work with them, very actively involved. And we work with the National Institute of Migration in Mexico too. Now, in the promotion of binational public awareness of migrants' health issues, well, we do workshops of health promotion in oral health. We train health promoters that work in the United States, and then they come down to Mexico, and we teach, actually we give information, our model of care, so they can come and better serve the migrant population. We also signed some binational health collaborative agreements. We have signed one with Oregon and New Mexico, but also we do some agreements with the community health clinics that provide services to migrant workers in the United States. For example, they go and work with, they do agreements with Oaxaca, with the state of Oaxaca and the state of Puebla, where many migrants are working in California or in New York. And with these health community providers, they come down to Mexico and get to know what are the beliefs and the practices of the health practices of Mexicans, and that way they can understand better what the migrants here are expecting when going to the physician's office, and how they can deal more with more culturally appropriate tools in order to have more impact in the healthcare they provide. So with this training workshop with the promotoras, that's a very successful thing, and the collaboration we have with the National Center for Farm Workers' Health. I don't know if you know this National Center for Farm Workers' Health, but it's a big association all around the United States that affiliates the health community clinics. And we are very much involved with them. We work very closely with them, and the headquarters are in Austin, in Texas. And of course, one of the activities that we do is the Binational Health Week and the Binational Public Policy Forum that we organize every year. Now, our main association with the United States is the Mexico Health Initiative, which is funded by the University of California and also by the California Endowment. And this is to raise awareness about problems that have health problems that are facing the migrant population in the United States. So some of the activities we do this week, actually we did it this week. This week is the Binational Health Week. So they are in the 45 consulates that are in Mexico. Mexico has the most consulates, of course, in the United States. There are 45 of them spread around the whole country. And they do health fairs, and they do some screening for diabetes, let's say, for oral dental health they give, and also screening for hypertension, diabetes, etc. And also these community health clinics also do this for the migrants, and like around 3,000 non-government organizations that are working for the migrants' health do also these outreach programs during this health week. So we are going to have the closing of this Binational Health Week tomorrow in Nuevo Laredo, Mexico, and there's the report of all the activities done through this Binational Health Week. So some of the activities, okay, there are, as I was telling you, 100 of organizations and thousands of volunteers work on that. The Mexican consulates, then outreach to special population, to agricultural workers and indigenous groups. That's done this during this week. We also publish reports on the health trends of Mexican immigrants living in the United States. Each year we come out with several publications on this topic. This year we came out with 2 of them, one done by the University of California and one done from the National Institute of Public Health in Mexico. I didn't bring any copies of them, but we have them available to you on the web. And also so the publication report, and well, it's intended to provide policy change also, no? on the migrants' health. We did it this year in LA. We did 1 year, we do it in the United States, and the other year in Mexico. Last year was in Guadalajara in Mexico, and this year was in Los Angeles. Next year is going to be in Zacatecas. So all of you are invited to participate in that. Now, the third strategy that we do in this program is other activities to provide support to the services of the migrant population. For example, we have the Mexico-Canada Temporal Agricultural Workers Program. We have signed this with Canada since 1973. So it has been like 35 years in place. And we send around 12,000 Mexican workers to Canada to work in the agricultural fields. Of course, this is a program, very controlled program, in which when they go there to Canada, they already have a signed contract to work with farmers. And there are charters, hundreds of planes take them there, and they come back. So I think this is a model that we can reproduce for the United States. Maybe one day we could do that. Also, we have the SIG National Program, in which this is pretty much on the undocumented workers here. When they get, pretty much they get renal failure due to diabetes, and suddenly they are dying, they get into the hospital, and then the hospital give them some treatment in the United States, but of course they don't have health insurance, so they call me, and then I provide health, and I see where they are going to put it in a hospital in Mexico. Usually the hospital in the United States pays for the airfare for the person to go down to Mexico, and I'm in charge of looking where to provide health care to them. Another program is the Ventanillas de Salud. This is a very good program that is Health Windows, it's called, and they work in the Mexican consulate. Right now, we are financing 17 of these Ventanillas de Salud that are placed, of course, in the border and in LA, and those consulates where there is a lot of population of migrant workers. Of course, Chicago and New York, where there are a lot of migrants working there. And these Ventanillas de Salud, what they offer is information on where they can have access to health care, what type of insurance policies they can get, they can afford. And they are insurance like HealthNet in California that have designed a package for insuring migrants that are low cost and that they can have access to these programs. So? Okay, so this is the third one. And finally, the fourth strategy is to promote research on migrant health. We do this with the University of California and with CONACYT, which is an institution, the Science and Technology Institution in Mexico that provides funding. UC provides funding, and the California Endowment provides funding too. So, well, this is, in very quickly said, the migrant health program that we are doing. So thank you very much, and if you have any question, I will be glad to answer them. IMSS Oportunidades or Oportunidades in general? Well, we have two Oportunidades program. One is the IMSS Oportunidades and the other one is the Oportunidades. The Oportunidades program is a model actually in addressing the poorest, addressing the health and nutrition needs of the very poor in Mexico. And it has been in place for the last 10 years. Very successfully, by the way. So what they did is a program that is aimed to targeted to the poorest population. And of course, the population, unfortunately, in Mexico, say indigenous population, is pretty much synonymous with poorness. So the extreme poverty that we have. We estimate that we have like around 50 million people living in extreme poverty conditions. So the Oportunidades program, what it does, it tackles education and health and nutrition. And so they go, we do a survey of the families. Well, first, through socioeconomic indicators, we target the counties where the most quantity of population, of poor population lives. Then we go to do a survey to each family to determine the poverty level. So if they're underneath the poverty level, then they get a package in which they go to the clinic and they go to school free of charge. Well, schools are free of charge, but they get a scholarship. And if the girl is in school years, if it's a girl that's going to the school, they get double than if it's a boy, because of the bias toward against women that say no, they don't need to study. They rather go work in the house. So this is an incentive for the parents to send their girls, their daughters to school. Now, if they are detected that they have a child with undernutrition under the age of 5, then they receive a special meals to deal with the undernutrition. And so mainly that's the problem. And of course, it's like, in order to receive this aid or the scholarship or the meals, they have to go to the health clinic. So they have, I don't know how you say it, but okay, nevertheless, they have to go to the clinic in order to be able to receive the benefits of the program. And it has been very successful so far. They have done several evaluations, and the undernutrition has improved very much. I didn't show you the slide, but from the National Nutrition Survey that we had around, overall in Mexico, around 19% of undernutrition on children less than 5 years old. Now we are around 5 or 6% only. Now our problem is overweight and obesity. So it's a good problem.
Mexico's had we did an Institute of Medicine collaborative conference with their Institute of Public Health. Mexico's an interesting country because it has a bimodal distribution of populations. One is the very poor. For kids, we see failure to thrive, severe malnutrition. But the other side of the same country, you see this growing population of obese children. In the United States, the most obese population is the Mexican-American population. Mexico is about 10 years behind us in terms of prevalence. So one of the big issues for us here is the obesity causing chronic disease, particularly among Mexican Americans, the issue of diabetes. We have resources to some degree to deal with that. Mexico won't have the resources to deal with the explosion of diabetes. So I guess as I listen to your talk, beyond this issue of obesity, there are a lot of things that map out that you're doing that sort of one don't know about, and two don't really interact well with to get them to work together. What have been some of the barriers for Mexico and the U.S. to work together on things like this?
Well, the main problem is that, as I was just with Senator Gil Cedillo, and he's saying that he was calling her, he phrased it like saying the anti-immigration hysteria in the United States. But it's really, because we do all this health week and all that, and what I have seen from the 3 years that I have been in this program is that our main partners in the United States are non-governmental organizations that are really the ones that are providing health to migrant Mexicans, or migrants in general. And so I was very encouraged by last year having another partner who is the California Health Department. So really, I'm doing some work, so I'm very encouraged about that, because we're planning now. I was yesterday in Sacramento giving another talk on this, and also planning a program that we want to implement in California and in Mexico of preventing cervical cancer to women, to Mexican women, who apparently they have that problem is high in migrant women. So, and now with them, I mean, we're looking for financing, and we're pretty much we're developing a strategy of social marketing on that. So I'm very glad that the California Department of Health Services are interested in this. And actually, on the Binational Health Week, Mark Horton, that you work, who is the head of public health of California Department of Health Services, was there. And so we have several programs going with California in particular. So that's encouraging. But the main problem is that the federal people, they never arrive, no, because they don't want to get close to us. Or, well, I can understand it also, no? I can understand it because of the political type of environment that we are in. Actually, many of these non-governmental organizations are telling me how tough, actually not only the non-governmental organizations, even the California departments, they have a lot of problems getting financing for these type of activities.
Yeah, I was just going to ask you the Canadian model that you mentioned, you've been doing that for 35
The
years.
which one, excuse me?
The Canadian.
For 35 years.
35 years.
Yeah.
I'm just curious what the Mexican government has done to suggest that or work with the U.S. government to implement a similar program here in the U.S.
Well, I haven't said anything. We had the intention of going to the embassy in Mexico, to the State Department guys, and saying, I think they have thought about it, of course. Actually, there was one in the 50s, 60s, no? In the 50s and 60s, the Bracero program.
It came up again last year, I thought, here, and Bush brought it up again, I thought, but it didn't get very far.
I don't know why they don't want it. I mean, the main problem is acknowledging, and that's, I think, the problem. To acknowledge the American people or the government of the United States, acknowledging, and the American people too, that you are in need of these type of services that nobody does, no? And once you acknowledge that, then we can say, like Canadians, the Canadians they do, because otherwise, but Canadians, they have a very small population, you know, no? So they have to import people from everywhere to work, and no matter where, they need workforce. So once you acknowledge that, then we can say, what I would say is, okay, who's gonna work as a gardener? Who's gonna work like a domestics? Or who's gonna work in restaurants? Who's gonna work in construction? And so we built a huge bureaucracy, but then everything will be controlled. That would be, can be a solution.
So I have a question about your allocation of healthcare dollars, because the United States is pretty dismal as far as what we put into prevention versus treatment. But when I've been to Mexico, it seems like you have a different allocation and emphasis on immunizations, literacy classes for women, preventive services. How do you fare on that?
Well, for example, yeah, we do, a lot of money goes into these preventive and promotion services. For example, vaccination. That's one of the successful stories of us in terms of public health measures. We have like 98% of our children under 5 have their complete schemes of vaccines done. So we have a very low incidence of diseases preventable through vaccines.
98% of all children?
Of all children, yeah.
And
That's like
actually, that program was spearheaded by a former Stanford medical student in Fernando's class.
by Jose Ignacio. He was the head, Jose Ignacio Sanz was the head of the vaccination program. So actually that was a crusade pretty much. The problem we had is just, so you see these different systems of health systems that we have. So the main problem to reach the objective of covering all the children with vaccines was to coordinate among ourselves. So that was Jose Ignacio, Dr. Santos' great accomplishment, to seat everybody in the same table and say, hey, let's get coordinating with, I mean it's a complex organization, so it's complicated to get that. Then the investment in the whole cold chain, no? You say it like that, or I don't know how to say it.
Yeah,
For example, the refrigerators, the terms that you have, because you have to go, I mean, they have to be cold, no, in order not to spoil the vaccines. And all human resources that we have to put in order to go to rural areas and to the more isolated communities in Mexico.
One of the vaccines, human papillomavirus vaccine, would be good for Mexico, but the issue is that the pharmaceutical that made it wants to charge, I think, $150 per shot. So
Right.
Mexico's had to determine whether they're going to spend $150 and that's 3 times, so $500 per person, and I think the answer to that right now, what I understand is no.
Yes, it's too expensive, yes.
So, you have countries that basically, and Mexico's in a difficult situation because while the pharmaceuticals recognize Africa and other countries around the world as being impoverished, they don't recognize Mexico as being impoverished. So even though we're right next door, they continue to sell the products to Mexico as they would within the United States.
So, but the only exception is the vaccines, because
Yeah.
the Pan American Health Organization,
Right.
which covers Western Hemisphere, they have a revolving fund. So Mexico has done, they have probably, so they get 15 vaccines for $13.
Right.
For coverage for all, so each child it costs $15, $13.98 to pay for all the vaccinations for one child. And I can assure you that's not what we pay for our vaccines in the US, but the way they do it is it's in economies of scale. So a lot of the Latin American countries through the Pan American Health Organization, they buy their vaccines in bulk. So the companies can give them so when Brazil buys, they basically subsidize, say, Haiti, so that because the cost is much cheaper for them to produce the vaccine. And that's been one of the success stories in terms of production or purchase, but
Yes.
it hasn't really held up, for instance, in nutritional supplements or other areas, because it's harder to coordinate that.
Mm-hmm.
Any other questions? Yes.
Is the health care system in Mexico the largest federal spending?
Excuse me?
Does most of the tax, do most of the tax dollars in Mexico go into the healthcare system? Is it the largest program that the government pays for?
Not quite. I think it's education mainly, and then health. Yes. Yes, everything is subsidized. So in Mexico we have the mentality, well, as I was telling you before, like a welfare state. So we should provide education and health for all. And who's responsible for that? The government. So that's why people don't have any prejudice in our tax money going into health for the poorest.
As opposed to here, where we just killed a chick.
So
Yes.
how I know we were talking earlier about how will you propose to follow migrant health successes or evaluation of migrant health programs in this country, given that people are mobile?
Yeah.
Or how do you think you'll?
Well,
be
that's
able to
one of
do
the
that?
questions they always tell me. Well, how are we going to evaluate if these activities have something to do with it? And I haven't figured that out really. I think that's a good topic in order for financing some research, no? In which, because I can't do it. I mean, we don't have that. I mean, I don't have a staff like it. It's pretty much myself and a couple of other guys who are doing the migrant so the idea is that, but we have some monies there, no, that we can use for financing some research on
So
this.
does UCOP provide? Because UCOP used to provide some University of California Office of the President, didn't they? So through CHI,
Yes.
Are they still providing funds?
Yes,
like
they are
that? 'Cause
still.
that would be something that.
They are still, but they don't. I don't know why don't. Yeah, that's a very good point, and I'm gonna talk about California that has a lot of money. I mean, the University of California. Why don't they do if they are pouring this amount of money to the Mexico Healthcare Initiative, they might as well allocate some monies in order to evaluate not only the Mexico Healthcare Initiative, but also my program, because we are tied in as partners.
Well, and the thing that is true in this country as well is public health is not very good at doing evaluation. So there's always programs that are put out, and yet very little is done to evaluate how well the programs work, or whether changing the program might make it better or make it cheaper, or, you know, so those are important things that I think because it's based in a university, they might be interested in
Right.
evaluation. Because I can think of some ways where you could do it. I mean, more than longitudinal, maybe cross-sectional.
So I want to thank you for coming and giving us a talk and informing us about the challenges ahead.
No, on the contrary, thank you very much.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.